This is a case of a 43-year-old female who presents with chronic daily headaches and jaw pain. She states she does not grind her teeth, but she's always clenching them together. She says the pain seems to be happening all through the day and all through the night. And she does hear popping in her right jaw, and it's very loud. She indicates that she did have brain surgery 2 years ago because of headaches brought on by cavernous malformation. She states she's not sure if her current headaches could be due to the fact that she had this surgery before or if it's making them feel worse. So for the history of the present illness of the jaw pain, the onset 10 years ago, she's been having popping without pain, but in the last 3 months, the popping has increased and it's causing pain. She believes the causation is clenching that starts usually in the morning. The location of this jaw pain is on the right jaw. It's an achy or sharp pain. It's daily, it's continuous, it's moderate to severe. Nothing really makes it better, and she's not really sure what makes it worse. For the history of her headaches, they started 4 years ago. The causation was cavernous malformation. The location of her headaches are occipital, bilateral, temporal. It's a throbbing or a pressure pain. She has light and sound sensitivity. They're daily. They last about 1 to 3 hours. They're moderate to severe. And again, nothing really makes them better, and she's not really sure what makes them worse. For her sleep history, she does claim that she awakens 5 to 6 times every evening while she's sleeping. She does not snore or grasp for air that she's aware of. When giving her the Epworth sleepiness test, she scored a 4, which is a normal value. Her medical history is positive for seizures, chronic daily headaches, epilepsy, anxiety, depression, and hiatal hernia. Her current medications are calcium, vitamin D, Lamictal, and Vibrad. She has an allergy to Secor, Septra, sulfa drugs, and Augmentin. Again, she had brain surgery 2 years ago. She's had gallbladder removal and gastric bypass. Her family history is positive for high blood pressure and cancer. For the social history, she did say she clenches her teeth and she holds tension in her neck. She does report being stressed, and she has a history of mental health treatment. For the objective exam, when palpating the craniofacial muscles, the right masseter was of moderate pain with referral to her ear. She did have some mild pain on the left masseter, some mild pain to the anterior temporalis, both sides, moderate pain to the SCM muscle on the right and mild on the left. For the trapezius, she did have mild pain on both right and left. When palpating the temporomandibular joint, the right dorsal condyle did give her severe pain. This patient has normal blood pressure, normal pulse, weight. Everything was pretty much normal for the glands and the facial jaw occlusal structures. She had a normal opening of 45 millimeters. Right-left lateral was normal at 10 plus millimeters. When listening to the joint on the right-hand side, I did hear a click with the stethoscope. The intraoral exam was all normal as well. Oral tissues were normal. The contact was normal with the mylar. Salivary glands were normal. We took a panoramic radiograph, and everything was within normal limits as well. So for the assessment, I diagnosed chronic migraine without aura, myofascial pain, internal derangement, capsulitis, and sleep disturbance. For my treatment plan, I gave the patient a myofascial protocol with avoidance therapy and stretch and then rest. I recommended nabumetone for the joint. I gave her a referral to a neurologist to evaluate her chronic daily headaches, a referral to physical therapy as well, a referral for a sleep evaluation, and a referral for a psychologist for stress management. I recommended a night guard. The consent was signed and impressions were taken. For the prescription, nabumetone 500 milligrams, 30 tabs, take by mouth 1 tab twice a day. For the next visit and future visits, we'll deliver her night guard. We'll evaluate the jaw pain. The patient's aware of possible future TMJ MRI, TMJ steroid injection or trigger point injection, or arthrocentesis if conservative treatment is ineffective. We'll evaluate the effectiveness of the physical therapy. We'll request copies of the clinical notes. I will request notes from the neurologist and from the sleep evaluation. So as her follow-up visit, the patient reports the jaw pain is decreased with the night guard, nabumetone, and physical therapy. But she's still having issues with sleep disturbance and her chronic daily headaches. The MRI impression is as follows. There were multiple cavernous hemangiomas scattered throughout the brain, postoperative changes related to partial left temporal lobectomy, and no abnormal enhancement after contrast administration. Now, when talking to the patient about this MRI result in her visit with the neurologist, she felt that the neurologist was unconcerned about her multiple hemangiomas, and she's seeking a second opinion for another neurologist. Well, as you remember, she was awoken in the middle of the night 5 to 6 times in the evening while she's sleeping. And so I did give her a sleep evaluation referral to a sleep doctor. We mentioned that her Epworth Sleepiness Scale result was only 4. Well, what is the Epworth Sleepiness Scale? So this is a subjective measure of patients' sleepiness. The test is a list of 8 situations in which you rate your tendency to become sleepy on a scale of 0, being no chance of dozing, and up to 3, which is a high chance of actually dozing. When you finish the test, you add up the values of your responses. Your total score is based on a scale of 24 points, 0 to 24. The scale estimates whether you're experiencing excessive sleepiness that possibly requires medical attention. There are multiple versions of this test, but most of them agree that if you score a score of 10 or higher, then there are significant daytime sleepiness. This patient only scored a 4. However, with her clinical history of waking up 5 to 6 times, I felt that it was important to give her a sleep evaluation referral anyway. So sometimes clinical judgment will need to be taken into consideration, even though this screening tool did not show positive for the daytime sleepiness. So she saw the sleep doctor. Her evaluation shows underlying depression and acid reflux. The sleep physician recommended Prilosec. The patient said she had no stomach problems since her gastric bypass surgery, and the Prilosec has not helped her with her sleep. So, what does the research say about this? So, I found an article that discusses this very situation with sleep disturbances with acid reflux. So they state that gastroesophageal reflux is considered to be a cause of sleep disturbance, whereas proton pump inhibitors like Prilosec is reported to improve insomnia associated with this reflux disease. In a randomized, multi-center, double-blind, placebo-controlled trial with 176 patients, the results show that PPI administration is effective only for insomnia in patients with reflux symptoms. And as you remember, this patient has no symptoms since she's had her gastric bypass surgery. In another randomized controlled trials of patients with insomnia and comorbid depression, the group receiving cognitive behavioral therapy for insomnia plus the treatment as usual had significantly higher quality and quantity of life lived than in the usual treatment patient alone. So in this case, she is taking medication for her depression, but I did give her a referral to a psychologist to also see if we can get to the bottom of the depression, her stress, and possibly her insomnia.